Well, I want to thank everyone for being here. I know it's a big sacrifice because the Blues are playing right now, so appreciate it, and thanks for having me. We're going to talk about concussions. I know it affects every one of you guys here, either directly or as a support person. But as a doctor, before we talk about anything, we always have to make sure we talk about the right stuff. So we always talk about a couple of different things just to make sure we're clear on what they actually mean. Traumatic brain injury is basically any trauma to the brain. We categorize them between penetrating, like a gunshot wound, and non-penetrating, like a fall to the ground, or anything that doesn't make the skull break. So that's the big general category of everything that happens to the brain. Within that, we have what we call closed head injury, meaning that the skull did not break. So for example, like a gunshot wound would not be a closed head injury, that would be open. Someone taking an axe to the head would be open. But a fall to the ground would be closed. And a car accident, without disrupting the skull, would be a closed head injury. There are a number of components that go into the closed head injury that we want to talk about. There's four main ones. One is, as far as when it comes to categorizing how the injury occurs. All right? So there's four things that happen to the brain and the surrounding structures. Some parts of the brain get stretched. So that's basically called diffuse axonal injury, where it's different parts are getting stretched beyond their normal limit and they get injured. Some parts are getting compressed. Some parts are getting rubbed against the inside of the skull. And then there's also the blood vessels that go to the brain that get affected. So, for example, I'm going to switch this side and look at the actual anatomy a little bit. Ignore the writing on the background, just look at the brain part. The brain, we know we have the big part of our brain is on top. It has two parts, the left and the right. It's covered by a very thick membrane, not only on the outside, but also within it. So for example, there's a very thick membrane that comes right down here to hold these two parts separate. But then there's other parts that go between the two parts of the brain and communicate. So what happens, let's say you get into a head injury and you're going to have like a whiplash. So as your brain moves, let's say your brain is going to move this way, this part of the brain stays where it is because there's a membrane that holds it there. But this part is going to go towards the skull and push the spinal fluid out of the way. All the nerves that are running side to side that are connecting the two sides of the brain, they're all going to get stretched. That's where the stretch occurs. Those part of the brain that hit the skull, they're going to get compressed. So that's going to be a different kind of an injury for them. Some of them will actually rub against the brain, against the inside of the skull, and they get a blood clot in them. That's called a bruising. We call that a contusion in medical terminology. And then the blood vessels that surround the brain and go inside it also get affected by this stretching and compression. If the stretching is bad enough, the vessel goes into a spasm, meaning that it gets smaller in diameter, so less blood flow goes through. If it's bad enough, you can get a stroke. If it's even worse than that and tears, you can get a big blood clot. So depending on what part of the brain hits what and what part gets stretched, that's where you get all the different dysfunctions that you will get. Some parts of the brain will get affected worse than others. So you'll have some things that are worse off than other parts of your body. Just about the anatomy, I'm sure you guys know this part. The frontal lobes, which are sitting in the front, they deal with the strength on the other side of the body. They deal a lot with your personality and behavior. Right? They also deal with you being able output of speech. So the way if you stutter, you have a lot of pauses, the right word doesn't come to your mind. That's all frontal lobe. That's on top, in the front.
Which sphere is that? Does that affect speech, left or right hemisphere?
So all the right-handed people is the left side, and about 70-some% of the left-handed is also the left side. The temporal lobe is lower down. That's more over here. It deals with a couple of different things. One is the understanding of speech. So when people talk to you, it actually makes sense. Deeper inside, way down deep here, down deep here, there's a structure called amygdala, and next to it is the hippocampus. They deal with memory formation. So if I tell you something, your short-term memory is going to be formed over there. From there, when there's enough repetition, it'll go to the appropriate part of the brain and stay there as a long-term memory. But that's one of the reasons why you have a lot of memory issues with head injury, because those nerves have a different structure than all the rest of the brain. The whole rest of the brain has 6 layers, and it's very robust. That part has only 3 layers, and it's very opposite of robust. And the blood vessel to it is very finicky too, very easy to spasm and very easy for the nerves to die. So that's why memory gets affected so much with head injury, because the structure of the part of the brain. Back here is the occipital lobe that deals with your visualization and understanding where things are as they move, what is this object. Parietal lobe is the main association area. So everything that requires combination of vision, touch, hearing, it's processed over there. Mathematics even. So as long as we understand the anatomy, we can understand a lot more about what happens to you and why it happens. Now, I'm sure you guys all have seen this. Whenever there's an acute brain injury, initially in the 60s, 70s, whenever, there was an issue with when the ambulance driver was trying to explain to the hospital what kind of patient he was bringing. So the hospital was never really prepared. So what they did was they designed this Glasgow Coma Scale. And what it's used in acute traumatic brain injury. Acute is usually the first couple of days, maybe 3-4 days, but usually it's just for acute. So it's a way for clinicians to speak with each other and having a relatively quick understanding of what's going on without having to go through the whole neuro exam, because it's included. What it involves is it has 3 different parts that you test to get the score. Your best eye movement, your best eye function, your best speech function, and your best motor function. The reason I'm saying the best is because let's say somebody is actually hemiplegic, like the whole half side doesn't work, but if the other side works, they get a full score. So it's a little bit of it's got some pitfalls in it, but it's pretty good for almost all the rest of the cases. So we use it a lot, and it goes between 3, which is nothing in all 3 categories. You get 1 for each of them. So that's the minimum is 3. The maximum is 15, where you get 4, 5, and 6. So you'll see a lot of times we categorize things by GCS score. So in fact, head injury is categorized by GCS. 3 main categories of head injury, right? Whether it's traumatic or closed head injury, the 3 main categories. We have mild, moderate, and severe. We define them by their GCS scores. We also define them by the length of time for loss of consciousness, although I'll show you a different slide on that in a second. But any GCS between 3 and 8 is severe. They're usually comatose. Moderate is 9 to 12, and mild, which is what we call concussion, is between 13 and 15. So they can be awake and alert and just be very confused, and the speech may be a bit off. Now, unfortunately for the women, they're more prone to getting concussions or any kind of head injury. There was only one study that looked at it, and it seemed to implicate the fact that you guys are just not as muscular as men are. So you have a more tendency to have a harsher whiplash than a guy would, just because they have more muscle. That's what they implicated. Nobody has written anything like that in stone. But anyway, so remember, concussion is a mild head injury. But within concussion, you have mild, moderate, and severe. And it depends on the length of time that you were unconscious and how much memory loss you have. It's called post-traumatic amnesia. So after the accident, how long were you kind of not remembering things? Depending on which system there are, and I just only mentioned 2 of them. AAN is the American Academy of Neurology. They're a pretty good group. Cancer system, a lot of people use that too. But you can see how there's a little difference between them. But again, mild, moderate, and severe. If you think just about loss of consciousness, you have no loss of consciousness, less than 5 minutes, more than 5 minutes. Very simple to do. Whereas here, it depends on how much confusion there is, and loss of consciousness automatically makes it a severe. So this is a little bit, the AAN is a little bit less strict. Bless you. Symptoms of concussion. by far the most common is headaches. As you can see, there's so many other things going on there too. Now, this is a combination of a number of studies. So the population that went into to look at this study to come up with these percentages looks pretty robust. And you can see it's a very significant amount of stuff, some things that we don't even think about. But headaches, we see them very common. Difficulty concentrating, fatigue, drowsiness, difficulty sleeping goes with the fatigue as well. Sensitivity to light and noise, memory deficits. Anyway, I'm sure you guys are all familiar with those symptoms. And then we have post-concussive syndrome. I'll show you, we have three main societies that decided in their own arbitrary way, concussion should only last this long. Anything past that is called post-concussive syndrome, meaning that those same symptoms that you had just continued on. Now we're past the concussion part. Now we're going into what's called post-concussive syndrome. And it depends on the organization. And here's those three. World Health Organization. The DSM-4 is basically from psychiatry and neurosurgery, which is really what I go by. The reason I like the neurosurgery one, besides the fact that I'm a neurosurgeon, I'm biased towards it, but it has the most number of symptoms that are in there. You'll see there's like 40 of them that I kind of compressed into just a couple of tables. But you'll see a lot of them have, the main things are in common. They all look at headaches. They all include dizziness, vertigo, which is the spinning sensation. Ataxia is the balance problem. Fatigue, irritability, aggression, sleeping problems, memory problems are included in all of them. So these are all the things that are in common for all three categories. And then they start to have their own differences now. DSM-4 and neurosurgery deal with visual impairment, personality changes, whereas the WHO does not. And neurosurgery has a lot more other symptoms because we see a lot of these on a regular basis for us. If you have vertigo or dizziness, most likely you also have nausea and vomiting because it's the same part of the brain that deals with it. So we just have a lot more of these symptoms just to make sure that we catch all the people that need to be caught in these categories. Neck pain is very common. We'll talk about that briefly. Just a lot of the musculature that gets pulled during the whiplash and also the joints in the upper part of the cervical spine. So that's probably the most common thing to inject for post-traumatic headache that radiates like this and goes right behind the eyes. The upper cervical facets, the joints that allow the neck to move, is what we actually inject for those. The reason I have depression in bold is because it's the hardest thing to treat and it's the deadliest thing to see. That's what really leads a lot of the people with different kinds of head injuries to commit suicide. So we need to be aggressive with it, but it's very hard to treat. So we try our best. But that's why I have it there, because a lot of times you guys are, the patients are in denial and they don't know. They just don't feel right and they do bad things. With anxiety also comes what I call situational PTSD. I'm going to talk about that in just another slide. Everybody knows what PTSD is, right? Post-traumatic stress disorder. What I call situational PTSD is, for example, let's say you were in a car and a semi-truck hit you. From that point on, every time you get in a car, you're scared. Your heart races, you're sweating, you're fearful, you don't want to be in the car, you act different because you're scared that another truck is going to come. Is it going to really happen? No, I mean, the chance of that is so minor, so low. It's probably not going to ever happen again. But because you were involved in it, you have this gut reaction that, oh my God, I'm not going to be able to sit in this car. So that's what I call situational PTSD. Very debilitating if you have it, especially because if you have to drive to work. How are you going to do that when you don't want to even get into a car because you're scared? I didn't have a good place for this one, so I just put it here. Second impact syndrome. We see more in athletes because the rest of us usually take some time off to recover from the first concussion before we get to a second one. So if you have one head injury and you haven't recovered from it, the second one is almost like exponentially worse instead of just additively worse. And that's what leads to a much worse outcome. If you have 2 bad head injuries in a row, the chances of mortality, unfortunately death, is at least 50%. Just to think about it, because that's why a lot of times we take you guys off certain activities for a certain period of time, because we want to make sure we really minimize the second impact syndrome. So probably about 30 to 50% of the patients I see in my office are because of concussions. How do we treat them? So we don't have a magic wand. We can't treat all the symptoms. Sometimes some of the things your body needs to recover itself, so we just promote that environment to get it there. But the basic philosophy is to decrease or break the cycle. The cycle is you have whatever dysfunction, whether it's headache, memory problems, whatever it is that's bothering you. Most of the time it ends up being, in the long run, personality changes and memory problems. But whatever that problem is, causes the patient to have a certain frustration because they can't deal with it. That frustration causes anxiety, depression, which is very common. That causes more stress, which causes worsening of the dysfunction. So our goal, the best place to break this cycle of badness is to decrease stress. We try to treat anxiety and depression at the same time. It's hard to treat it, but we will try it. But decreasing the stress somehow or another is really the key to get rid of this cycle, and then we can get you to actually have some recovery. Yes?
What part of the brain controls smell?
Smell? Yeah. So it's in the base of the frontal lobe, at the roof of the nose, right? And then it goes into a very primitive part of the brain, and it's very closely associated with that hippocampus and amygdala that I told you about. Yes. In fact, a lot of things are associated with that because we remember better when we have an emotion attached to it. That's why you'll remember some argument from 5 years ago, right? Because there was an emotion attached to it. And it's that primitive part of the brain that deals with it. Okay?
Yeah, because after my accident, I can't smell anything.
Right, so that's very common. Smell, and you notice taste is mostly smell, right? Because, right, you can taste some stuff, but probably not as good as before, right?
Taste everything even better.
Yeah? Okay, well, good. God bless you. Most of the time I see people, most of the time when I see people, because there's only 3 or 4 things that we taste with our tongue. Almost everything else that we do is actually smell. I mean, though we put it in our mouth, but it's a smell that goes up. So most people that I see, you lose smell fully, you probably only lost it partially or just got changed. But if you completely lose smell, then most of your taste goes with it, because most of our taste is actually smell. All right, so what are we treating? Most of what we treat, these are the main things that we treat. Obviously, I showed you a whole list of symptoms, right? We can't treat every single one of them, but most of what we treat is right here. And I'm going to go through each one of them one at a time. We talked about the actual anatomy of the part of the brain that deals with the memory loss, the hippocampus and amygdala. What they do is the injury there prevents you from forming new memory. All right? How do you get over it? Well, there's a couple of things that we do. Acutely in a hospital, they have to make sure that there's no extra pressure in the brain and things like that. So if you had bad enough injury, you get a CAT scan to make sure there's no blood clots, things like that. If there's extra pressure there, if it's a bad enough blood clot, they have to remove it. If not, they may have to give you certain medications to help things come along better. After you're done with the acute part, what do you do with the memory if there's dysfunction? Well, best part is practice, practice, practice. There's certain things that I usually send patients to cognitive therapy because they have a more structured thing than I can do in the office. And you spend a lot more time with them than you will in the office with me. So there's a few places that I personally like because I visit them and I've talked to the therapist, but there's a whole bunch of really good places. You go there and you need to learn a few things. First thing you gotta know is that there's no guarantee your memory is gonna come back. It may improve. A lot of it depends on your age, overall health, and other things that may be going on at the time of your accident that are beyond your control. If it does improve, that's great. Most of what I see is improves up to a certain point. but you don't want to be frustrated by it not being back to the way it was back when you were really good with your memory. So what do you do? Yes?
Question, I'm sorry. You said cognitive therapy. Is that like the speech therapy?
Yes.
Okay.
So speech, I'm sorry, speech is speech/cognitive. It's the same person that does both parts. And thank you, because that's going to come up in just a sec. But what they're going to show you is they're going to show you organizational skills. Right? So you have to make minor modifications so that things don't fall through the crack. Like the most common thing is when somebody calls you and say, hey, can you stop by Schnucks and buy ABCD? By the time you get to Schnucks, you've forgotten ABCD. So the problem is that they did it by a phone call. Well, what if they texted you? Minor things, right? But makes a big difference. Same thing the reverse. You're going to have the same conversation 4 times with someone unless you wrote it down. So instead of calling them, you can call once, text it. That way you'll remember, hey, I already had this discussion with them. So simple stuff. But they go over these things with you, and then when you see me back in the office, I usually go over just to make sure everything is extrapolated from what you learn to your life. They'll teach you a lot. You need to get as much as you can from them and see how it applies to your life. Everybody has a different life, so different things are going to apply to you. That's really the best thing for me, is to make sure you guys have good organizational skill. Because the more organized you are, the less frustration you have, because the less things fall through the crack. These are just some of the free apps that the therapist had told me I can share with my patients. So I usually have a handout in my office. If they're not bad enough to need to go to a cognitive therapist, I just have them do these. I just give them the app. I just give them the piece of paper in the office. Most of what I see is actually bad enough that they need to go to the cognitive therapist. Speech, again, mostly frontal lobe, combination of frontal and temporal lobe, deals with understanding it, processing it, and then putting it out. So it's kind of like a multi-part of the brain function, right? And some of it has to do with how well you understand and also how much stress you have. When you stutter or you're pausing, it's a combination of stress and other things because you don't have that word at the tip of your tongue or you're not sure how to express your thought. So what do? You stutter or you pause. So the best thing to do is practice, practice, practice. And they have a whole bunch of different apps for that as well. And we're just going to go past that. From what I hear, I have not been to these apps, to be honest with you, but I've had a lot of patients that have gone to them, and they love it. It's just on your phone, so you're sitting there, somebody's driving you somewhere, you can just sit there and do things. Very user-friendly. I'm sorry, go ahead.
Sorry, no, I had.
Do I need to go back?
No, you're fine. I had expressive aphasia.
Uh-huh.
So when I was doing my speech therapy, they would show me a picture and they try to get me to say the word. And sometimes I could, but sometimes I couldn't.
Right.
I would talk around it. I
Yes.
would say what the object did.
Right.
And it'd be like word tennis, like
Mhm.
just bounce until I found it.
Right.
So,
But eventually with practice, you get better.
yeah.
You may not be 100%, but you get better.
Right.
The point is to just get you to a point where you know, hey, I'm this good, but I'm not going to be frustrated if I'm not 100% every time.
Right.
Right? And that's what it is. The frustration and the stress that leads to anxiety and depression, that's what we need to break, and then you guys get to recover even better. Right? Okay, vertigo. Vertigo is that spinning sensation. Right? Who had vertigo?
My entire life.
Okay. Vertigo is a imbalance between the inner ear structures. Those inner ear structures are connected to your eyes. They're connected to the cerebellum, which is the back part of the brain, which connects you to your legs. So they deal with your balance, your ability to stand up and turn your head and be able to focus on things. So whenever I turn my head, my eyes don't go all over the place, right? Because the connection between my eyes and ears tell me where I need to put my eyes. And they tell my legs how I need to position my legs so I don't fall over. So multi-parts, so they all have to be trained, right? Because of the area that's involved in vertigo, nausea and vomiting are very common. So what do we do with that? Again, vestibular therapy. The vestibular system is the inner part of the ear that we train. There are certain exercises for it that are very stressful. and you train them by stressing it, but with the care of a therapist. I wouldn't do that at home by myself. It may not be good. But they do that. They do the exercises, and while they're doing all that stuff with you, I usually tend to put you on some medication to help relieve some of the symptoms, so you can actually tolerate your symptoms and not be so dizzy all the time. But again, practice, practice, practice until you get better. Doesn't always resolve, but it should get better. These are some of the things that the therapists give me for them to do at home. In fact, they go over it with you. Some of it is the eye movement, head movement. A lot of times, the neck muscles prevent you to have the right range of motion to be able to do these exercises. So they do a lot of therapy on that as well. It's very common to have PT with your vestibular therapy, and obviously gait training. So these are directly from their handouts that they gave me. Headache, probably like if it's not memory, it's headache that are the biggest problems, right? I mean, who doesn't have headaches? They're multifactorial. The most common ones that I see in whiplash injury is from the joints of the cervical spine. The joints are called facets. That's where the bones actually move against each other, so you can move your neck up and down and side to side. Most of the time when people have headaches, that goes from the back of the head, up front, or to the side and ends up around the eye, or right behind the eye. It's coming from there. And most of the time when people think that they have migraines, but it's really a cervical facet issue. From those joints, or near those joints, are also the nerves that come up, either to the top or to the side. So either it's from the joint themselves or from the nerves that come right by them. So that's, a lot of times you'll see us do injections. It's right in that area back there that we're trying to get either the occipital nerves or the cervical facet that are the main cause of the headaches. Sometimes you have just diffuse pain all over, not from the neck. I had one guy, he was in construction, and he was working with a crane. The hook of the crane was lifting up a chain, and it broke, and the crane came, smashed into the cabin right into his head. He did not have a cervical problem. He had crane smacking him in the back of his head problem. And that was causing a lot of soft tissue pain. That's neuropathic pain. Different kind of medication altogether for treating him. You know, different kind of procedures to get altogether. So anyway, it's important to recognize the different causes of the headache and try the best we can to treat it. Not all of them are treated the same way. Depending on what's going on, these are the most common medications that we use. Number one, gabapentin, also known as Neurontin. If you're allergic to that, it doesn't work so well, you're having side effects. A lot of times they switch you to Lyrica. And then you can go down the list. You can see Botox there. We're going to talk about Botox in a second. Injections, it could be from the muscles. As you noticed, there was that therapy picture for the neck muscles, actually moving them around to make them better. If they don't get better, you can actually inject the muscle to make them get better. The nerve blocks or the facet blocks. Probably the last thing is to either cut the nerves or stimulate them. We used to cut them even up to like 10 years ago. Whenever the nerve was dysfunctional, we used to cut them. Then we realized they actually get more pain that way sometimes. So it's better to stimulate because you can adjust them. So you can have some people that have really bad pain back here, they can actually put a stimulator back there to, by stimulating, you turn off those bad nerves. I'm very big on relaxation techniques. So whenever I see somebody in my office that has at least a good moderate degree of concussion, and they have a lot of anxiety, depression, and a lot of pain and things like that, and too much stress, if they don't know how to do a relaxation technique, I actually sit there and teach them one. Because it's very important to do that, to just get them to just step back from everything and just have a different perspective. And it really, really helps a lot. So you'll see me do that a lot with, on a lot of my slides. That's just my personal preference. Botox is used for chronic migraines. So you have to qualify for it. There's actually like indications for it that you have to meet. You have to have at least every other day kind of a headache. It has to be significant. It has to last at least 4 hours a day. You can have multiple migraine kind of headaches per month. So there's a whole checklist that your practitioner will check off. I personally don't do Botox myself, but I have a few colleagues of mine that do, so I refer to them if I can't fix you with any other way, and you're having a lot of headaches everywhere, that's what we do. What Botox does, it's a muscle paralytic, meaning that it just paralyzes the muscles around your scalp. Because when they tighten, you get this pressure pain. So what they do is they paralyze it. That way you don't have the pressure pain.
I had it in my hands and wrists and ankles and legs, and I'm guessing that's a different type of Botox.
No, there's only one type of Botox. Did you have contractures or did you have difficulty moving them and then they did therapy to move it? Yeah, so they needed you to not have contractions, so they gave the Botox so that they could have better therapy. Same Botox.
Yeah, well, I've only had, I had it once, and then I think like 2 days later, a couple more, I think they weren't happy with my movement in my hands and in my ankles. So I had it twice, but haven't had it since.
Okay, good. So with the headaches though, you can have them up to 3-4 times a year for the Botox for the headaches because they wear off at some point. Now in your case, you probably haven't had it because luckily for you, your muscles were able to loosen up. So that's good. There's actually a picture for the practitioner that tells them exactly where to go for these Botox injections. So if it's all over your head, there's a total of 31 places they can inject. And you're like, where's the one? It actually happens to be right there. But everything else is symmetric all over. Sleep disorder. You guys are almost all of you guys are of age to have kids or have at least nieces and nephews, right? What happens when somebody misses bedtime? They run around the house like crazy thingy, right? Because they're actually overtired. And you'd be like, this is like the opposite. You should be falling flat on your face and go to sleep already. But that's what happens to the brain, right? So the same thing with the head injured person. A lot of times they're having difficulty sleeping at night because they're overtired. They've been tired the entire day. They haven't slept good the night before. They haven't slept during the day. They've pushed themselves beyond their capacity. Now they're overtired, and now they can't fall asleep because they're so stimulated from within. So what I tell them, you got to break that cycle. Depending on how bad their head injury is and how much rest they need at lunchtime, most of us take 10 minutes to eat, right? But you get a half hour. Go in a quiet place, put a cap on, do a little relaxation technique, or just sleep. I don't care what you do, but shut down for a little bit. Same thing maybe at 5 o'clock, and then go to bed at about the same time, between like let's say 9:30 and 10 or 9 and 9:30. Pick a short time and go to sleep. I don't like medications that much for this because the side effects are so bad. Like if you, like Lunesta or what's the other one, I forget. Ambien. Ambien is actually really bad, right? Because if you take Ambien and you're not ready to go to sleep, you'll do bad things. So they're going to actually come up with like these big warnings on them now. So I prefer relaxation technique. If you do it laying down, chances are likely you'll fall asleep. If not, take some Benadryl. I don't like, no, seriously, I don't like those. Because remember, this is not a short-term problem. This could become a long-term problem where you need the Benadryl for a while. The last thing you need is some drug that's going to mess you up. Benadryl is not addicting.
I have a question.
Sure.
You've mentioned relaxation techniques a few times. Do you have like a go-to app, or what's like your go-to?
My go-to, believe it or
Yeah.
not, is what I learned in college. So that's what I teach people in my office. But I don't care what you do, as long as it helps you make you feel good. There's a bunch of different, if you pull up different websites, just write relaxation technique, there's a lot of different ones out there. The ones that I like for people who have never done it before and kind of are not like the type B personality, if they're more of a type A, is the kind that actually talks you through it.
Yeah.
I like what I call the active one, where they actually tell you, this is what I want you to do.
Progressive relaxation exercises. If you Google that,
Okay.
you'll get some apps for it.
Mhm.
Okay.
And there's I have several that I give
Okay.
to people so you can
Yeah,
tell.
Right.
I'll
I
chat
that
with you
one.
later.
Yeah.
I've tried some before, and sometimes they just get so cheesy that I'm like, okay, I'm just laughing. I'm not.
No.
even
Yeah, you have to
thinking,
mess
so-
around with.
So
Okay.
at the end, I'll show you how I do my relaxation technique.
Okay.
But it's one of many. I mean, when I was in college, I learned a bunch. I happen to just like this one.
Okay.
Doesn't knock down any of the rest of them. It's just everybody's different, and
Okay.
God bless them, right? So doesn't work for the one that I do doesn't work for the really hyper type A personality.
Okay.
You have to be able to relax a little bit. And those guys are so gung-ho. They're the ones that really need the progressive one. You need to have somebody talk them mellow, right?
A couple YouTube channels I'll watch. Like,
Yeah.
Melatonin is good too, if it works. Good. That's another thing that I tell people to do. Because the Benadryl wakes you up really dry. Melatonin does not. You actually get a good night's sleep with melatonin. So if it works for you, that's really good. I'll keep doing it.
or whatever. So.
All right. Big one, depression. Remember a few years ago, I think 4 or 5 years ago, when all these different wrestlers and football players were committing suicide? The depression from their head injury that was under-recognized, unrecognized. Everybody poo-pooed it. Hey, you're 6'8", 300 pounds. What are you talking about, a head injury, right? And meanwhile, they didn't have a life.
Didn't
they-
a lot of football players like commit suicide like
Right.
last couple of years?
Yes, a few years ago, right. And that's when they examined their brain, that was this whole big thing with chronic traumatic encephalopathy, right? That's where it came from, because they were looking at these guys' brain.
A movie on it.
Yeah, concussion, right?
Yeah.
I think it was called Concussion.
Yeah. Will Smith? Or no, who was in it?
I forget.
I don't remember.
I don't remember. It's been a while.
Might have been
I
in
think
it,
it was The Rock, maybe.
I don't remember anyway, but yeah, there was a movie actually called Concussion. I read the book actually by the guy that actually finally came up with this, and it was actually a very, very, very good book. What can I say? People with depression, they just basically feel like they're at the end of their rope, and if you don't treat it, that's where you get the bad problems. The problem is a lot of them are either under-recognized or just in denial. So you have to, when you look at them, I mean, I spend some time with them when I see them, and I'm like, you know, you look like depressed to me. Do you feel like A, B, or C, or whatever? You know, we go through a little checklist just to see. But you have to start everybody on a low-dose medication because you can't just start on a big dose. But it takes a while to get to a point where they actually can find the right medication and the right dose. It's a bit harder to treat than just the regular average person.
Do you have any like counselors you would recommend for
Y-
people who
You-
like? Cause I don't think I need medication. I just think I need to
Right.
talk to somebody.
Yes. There's a few of them out there. I don't recommend anyone over the other one because I've never really like sat there with them and talked in depth about what they do. But there's a lot of resources out there for counselors. I mean, you guys probably know a lot more than I can.
Yeah, we have a list of a
Okay.
few people on the brain injury resource list. If you call Alyssa, she can
Okay.
give you the names.
I'll make a note of that.
Yeah.
Yeah.
And be honest with you, I'm like not the medication guy. I mean, I'll start you on it, but I'm not the guy I'm not a psychiatrist, you know?
Yeah.
And I'm not going to play one. So I'll start you just to get you going, but I'm going to refer you out to someone to get it treated. Because you need to have somebody who actually deals with this every day, all the time. I just want to make sure we treat it in the most appropriate way possible, and the sooner you start, the better it is. Oh, just as an aside, again, relaxation technique for the ones that can tolerate it. And this is just a global thing, not just to do with head injury, but it has to do with also brain surgery, spine surgery, which are things that I'm familiar with. But I think also with just about anything else, when you add depression to it, they always have a worse outcome than if they didn't have depression. Every single study that I've looked at least from the neurosurgery part of it, talks about that. It's the one thing that we always used to ignore, and now we have to talk about.